Okay, hi everyone. I am appreciating that 20 minutes goes pretty fast. So I'm going to try to stay on time here. Today we'll be talking about kind of just an overview of what is anxiety. We'll talk a little bit about screening and some of the evidence base for some of the things that we can do to improve people's anxiety. And then I want to drill down actually and talk about two, since this is a Metro Denver chapter, of things going on right here in Colorado. Kind of some innovative cutting edge interventions to improve anxiety. So what we know is that there's a pretty broad range of prevalence to anxiety, and it depends on a lot of factors. Certain cancer types seem to engender more anxiety, or perhaps certain cancer types are just better studied. There's a lot of research in the breast cancer field, and we know a lot more about that than, say, some of the other types. We also know that different stages of cancer have very different impacts in terms of the symptoms of anxiety, and that certain demographics, women tend to have higher anxiety in the setting of a cancer diagnosis. I think it's really important to note that cancer really that anxiety can occur anytime across that cancer continuum. So just hearing the diagnosis, right, that shutdown. You have cancer. And then probably anything else that is said is not being heard by patients. Can affect communication, attention, cognition. During that active treatment or chemotherapy, radiation, surgery, what we know is that people have to harness a lot of coping. And sometimes that coping is adaptive, and sometimes it's not. And so it's also really important to note that some people have a much harder time. So pre-existing depression, back pain, lower functional status, having more comorbidities, those folks tend to experience more anxiety, in particular during their chemotherapy. When we get to this kind of post-treatment remission, this is a dramatic change in life, from going to maybe weekly or monthly appointments to suddenly maybe every 3 months, maybe every 6 months. And that can be really hard for patients. Also the feeling that they're not doing anything right now, right? They're not in active treatment, and that can really heighten symptoms. And so that is something that we really think about in that period of time. Returning to life roles, living with uncertainty, all these are major factors. Then when recurrence does happen, and we know it does happen, thinking about what can we do to bolster people's quality of life, having greater self-efficacy, having better social support systems, having family systems that manage hardship better. Those folks tend to have higher quality of life. Whereas when people have physical symptoms that are really uncontrolled, where they have problems like sense of hopelessness or demoralization, or even if their caregivers have a kind of a negative perception around caregiving, all those people tend to experience much lower quality of life and can really suffer from more serious anxiety. When we think about the advanced cancer, I think there's all the way to end of life, that there are a number of people that are experiencing significant distress. I also want to highlight that there are a large number of people that are not experiencing significant distress, even though they may be facing end of life. I think it's also important that we remember that piece as well. So some of the things that we think about in this time is that long-term survivorship piece, right? So they're maybe going back to their work, they're having to adjust to new roles. We know that the financial impacts of cancer is devastating, and they may have fewer economic resources to deal with. So having that increased sense of vulnerability, a lack of control over their environment, other just like conditional triggers of chemotherapy, like sights or smells that might bring on. We know a lot of people experience PTSD as a result of medical treatments. The ongoing issues around fatigue, and then just changes in body image and sexuality. We know that those are really important things, and we know, I'll speak for myself as doctors, we do a lousy job of talking through some of those issues. So I think it's really important when we think about, one of the things that's really important is we have to ask. right? We've got to screen for anxiety. And so I just put 2 screens. I'm sure you all are familiar with the NCCN distress thermometer. It's a really quick and easy way. I don't know that more complicated ways or more longer scales are any better, because those longer scales, they end up being harder to use. So I think it's better to go with the simple. On the left-hand side is or I guess you're right, is the GAD, we call it GAD-2, the generalized anxiety disorder. 2 simple questions around worry, right? Do you feel nervous, anxious, or on edge? Do you feel like you can't stop worrying or control your worrying? And so those are the sort of the ratings. We say a score of 3 or more, it deserves further explorating. Now, thinking about, there are some medical conditions that can actually mask as anxiety, and you should really think about that. Not having their pain control is a really important one. I have some really interesting art too on the side. This one is called Mind Vomit. I meant to do a better job of talking about the art, but I'm feeling the pressure of time. So having abnormal metabolic states, things like where thyroids get out of whack, where maybe even hematocrit is very low and people are feeling more fatigued and their heart rate's really high. Hormone secreting tumors, having anxiety producing drugs. How many have had a patient on steroids who just was like totally fine and then went bananas, right? So thinking about those other kind of underlying medical causes before we just say, well, they're really anxious. So this is Mark Rothko's painting entitled, it's Untitled is the title. So there we go. It's an easy one to remember. Thinking about some different approaches, so kind of focusing on problem-focused strategies, leaning into more emotional-focused strategies, or looking into meaning-focused strategies, and we'll go into a little bit more detail. It is important to think about cancer. There's some normal degree of worry, right? And when does it go from a normal degree of worry to anxiety? And this is a quick table just to think about some of the differences between those. A lot of it comes to how frequently these symptoms are occurring, right? So having think about it, and you're like, oh yeah, that's worrying me, versus I am stuck in my thoughts and just playing this like ping-ponging over and over in my head. Things are going to be okay. Things aren't going to be okay. And thinking about that and exploring with your patients, how much is this affecting you? How often is this happening? Some of the psychosocial interventions. This is Van Gogh's Starry Night, and the reason it's funny that Kasey and that they had mentioned Van Gogh, because he actually spent a lot time in a mental health facility called an asylum at that time. And they thought that this was a painting that he did at a time of his recovery, and that the clouds are really mandalas, and sort of thinking about his more having the psychological conflicts come into balance. So these are all different kinds of interventions that all have what we would call or refer to as level 1 evidence, meaning that there have been randomized controlled trials and even meta-analyses looking at these types of interventions. So group counseling interventions, mindfulness-based therapy. So those are some of those kind of mindfulness meditation. Breitbart has done some really important work in this space, thinking about hypnosis and relaxation, which is really important for those crisis moments, right? Those times of really increased stress, like a procedure or related to a scan. Using those kinds of tools are very helpful. Cognitive behavioral therapy and acceptance and commitment therapy, which I'm going to talk a little bit more about now. So transitioning to, this is the work of one of our Cancer Center members, Joanna Arch, who's a psychologist, who developed a acceptance and commitment therapy-based intervention, and she called it Valued Living. And she delivered this across some of the Rocky Mountain Cancer community clinics. And what she was able to show in her randomized controlled trials, that the patients who received the intervention were significantly, had decreased PTSD, and those who had the highest levels of anxiety had significantly decreased anxiety on follow-up. So the blue line is the intervention, those who received that valued living. You can see the decrease in their anxiety, and that little p is less than 0.5. That's a good sign, right? It's both statistically and clinically significant. One other thing that was very interesting is that she found when patients had their anxiety addressed and felt better, they actually had fewer missed appointments. And so this shows how like it can really impact things. And she's doing some kind of ongoing work now in the space of fear of recurrence. Okay, okay. A little word about some pharmacotherapy. Benzodiazepines can be very helpful tools. They're best in short term, right? So the long-term management, anything kind of over a month, it's probably better to consider SSRIs or antidepressants. Those drugs also have powerful anti-anxiety benefits. And then when anxiety is really refractory, antipsychotics can be of help. I think it's also fair to say in this moment is that the level of evidence and the data in some of the meta-analyses, in particular for people that are suffering from adjustment disorder or anxiety related to their cancer, is that these drugs can sometimes don't look that much better than placebo. So I think it also speaks to the fact that we need better interventions. And this is my unabashed self-promotion of a better intervention. So this is a study that is ongoing at University of Colorado. And we can, and we're open to enrolling outside of that. So if you're not in the UC Health system and have patients, let's talk later. So this is it actually funded through the National Cancer Institute, and it is a phase 2b study where randomized controlled trial looking at magic mushrooms in association with psychotherapy to address anxiety in people who have serious cancer diagnosis. So there are some core components of psychedelic-assisted psychotherapy, and this is kind of pretty consistent across the studies, most of the studies that have been published. The importance of set and setting, the person's mindset, and where they are. Are they in a safe environment? We're not giving people a bag of mushrooms and saying, head off to the mountains or go to the Fish concert and have fun, and that'll cure your anxiety. That's not what this is. This is really about an inward journey in association with therapy, both preparatory and integrative therapy. And it can be hard. Some of the folks that are having a dosing, they're not having a great time seeing angels and singing. Sometimes they're facing their cancer in almost like a visceral form, like a smoke or a black cloud. Sometimes they're feeling a sense of death and rebirth. I mean, it can be pretty intense. And I will say the emerging evidence, the preliminary evidence that our trial is based on is encouraging. I know here in Colorado, we're ready to kind of take this live. And I would say the cautionary tale I would say is like we need to continue to develop a solid scientific evidence base before this is ready to really, I think, take off, especially in our population that we all care for, which is people that have significant illness. So here's a quick overview of our inclusion criteria. The exclusion criteria listed is a pretty brief. It's extensive, and it really is. These folks that we're enrolling in our trial are very carefully screened. So the danger of having an ongoing psychotic episode, we try to prevent that by ensuring that no one has a diagnosis of schizophrenia, and no one in their family does. So it can be pretty exclusive in that way. And this is a little overview of the therapy. So this is my wonderful project manager in what is our dosing room. So our dosing room does not look like a chemotherapy infusion room. It looks more like a therapist's office. And like anyone who's ever been to an Airbnb and you get there and you're like, wow, this is a lot smaller than it looked like in the photo. That room is pretty small. I'll just say that. It's pretty small. But we have our 3 preparatory sessions, our dosing, and then our 4 integrative therapy sessions. And we'll be looking at outcomes at 3 months, and then everyone, whether they were randomized to our drug, which is psilocybin, or they are randomized to the placebo, which is niacin, everyone at 3 months has the opportunity to do an open label. You may be asking yourselves right now in our last 30 seconds, do people figure out if they got drug or placebo? And the answer is yes, most of the time. Most of the time they do know. We'll be looking at anxiety, depression, existential distress, quality of life, and that concept of demoralization or hopelessness we talked about. I know, I had to just go there. It's funny. And 2 seconds to go. I'm open for questions.